Hi, everybody.
Hello.
Hi.
Hello.
I've just been joined by Anna Bogdanova. I was just getting a little worried there, Anna. Cut that one right by.
I had some issues with my network. It's fine now.
Don't worry. Okay. Welcome to everybody on this latest webinar, EuropeActive focused webinar. This webinar is focusing on exercise for low back pain and various issues around the management of low back pain, which is a subject that's quite dear to me. I've sort of been involved in that area for a while. And we have a panel. We don't have, we're chancing our arm a little bit here, we don't have any PowerPoints. So we're going to try and make this discussion based and see where that takes us, really. We might all agree, we might not all agree. Let's again see where that goes. But just a couple of points of admin before I introduce our guests. You can ask questions. There's a chat function there. If you hover over the bottom of your screen, you can type in your question there. You can't speak directly, I'm afraid, and we can't see you, I'm afraid. But please put your questions in there, and I'll try and address those as we go, maybe a little bit at the end as well. This is all part as well of our sort of what I guess has been a reaction to the COVID-19 pandemic. And of course, you can go on the EuropeActive website and have a look at the various resources that we're producing around that. There's lots of stuff on there, lots of webinars, lots of papers, guidance, etc. Yeah, have a look. This is all part of that. Although I guess these webinars are trying to are becoming something more fixed beyond COVID-19, and will continue to do. We'll continue to do them. Okay, fine. Now, Anna is telling me that there's a problem with her sound. Anna, are you okay?
Yes, the sound is on now.
Is okay? Fine. Okay, good. Okay, so look, let me just introduce my guests for today. So we have Rocco Venizelos.
Really good pronunciation.
Not bad. Working on it. Rocco, I was first introduced to Rocco by one of our other EuropeActive ambassadors, George Ziros from Greece. Rocco is also Greek, living in the UK, right? Have I got that right, Rocco? Yes. Yeah. Rocco works at a very high level with athletes. Works on the tennis tour, I think. Rocco is also he'll describe his role or what he calls himself, but Rocco, I know, is also training to be a chiropractor, which is quite an interesting little piece. We have Joseph Korab as well. Joseph, hi Joseph, is based in the UK. Joseph is a chiropractor, but also working with exercise and in the exercise field as well. So he's got a really interesting contribution to make there. And we also have Anna Bogdanova, another one of our EuropeActive ambassadors. Anna is a personal trainer, does a lot of online personal training, based in Denmark. Anna, I think, is going to have some interesting contributions maybe on how we communicate around low back pain, some of the thoughts there, the biopsychosocial model of pain, etc., which will be a really interesting contribution as well. I would add that I'm obviously from a sort of exercise personal training background, but I'm also a trained osteopath, and I have a small clinic that I run alongside this job. So I have some insights to offer here as well. Okay, good. So let's start our discussion with a sort of opening question. I guess I'm thinking, what is the general approach to somebody presenting to you with low back pain, and maybe thoughts around sort of causes of low back pain? I know, Rocco, that we were having a discussion about non-specific low back pain and the implications of all of that. So maybe we start with you, Rocco, and maybe just take it from there. We'll see where we go. Don't be afraid to other panelists maybe to speak up if there's something that really strikes a chord with you with what Rocco says. Rocco?
regarding non-specific back pain, I think it's a blank term. If we go with the definition, non-specific back pain is defined as low back pain which has no attributable effects, recognizable effects to know exactly the pathology of what's going on.
Indeed.
So it's a thin line when we say it's not recognizable, because it will depend on the practitioner, on his experience, and on a bad day. Because especially there are protocols, and you know it better, because and you, Joseph, that sometimes you might have 10, 15, 20 minutes to see a patient. I'm not sure you're going to be able to do all the tests and have that kind of mentality at that point to be able to trace exactly what's the cause of the pain. And for example, I had the opportunity and the honor to work alongside Dr. Stuart McGill, which has been blamed for the anti-flexion, anti-rotation, all this misinterpretations of his work. And I've worked alongside a lot and other leading experts with that kind of mentality, that they're saying there's always a cause. If we can find it, we'll do our best. If we can, we need to find a better way to understand the underlying effect. Because I know we're going to be talking with Anna, and I've seen her brilliant job regarding the biopsychosocial model, and we can say anything regarding pain that has to do with the psychological, the social, the biological. But we need to understand that there's no question that the emotional and social side of people's life modulate pain. It doesn't start it though. There's always an underlying cause. Because if we go back to Neurology 101, and correct me if I'm wrong, our nerve roots, our nervous system, 45% is our visceral, 45% is our musculature, 10% is our sensory. So
Okay.
there's something there. You can use the non-specific back pain and say, until you find out what's going on, but I believe there's always a cause for pain.
Sure. Okay. Brilliant. That's very interesting. I mean, I wrote a course in this area some years ago, and it related to the UK sort of situation more than anything. 4 out of 5 people in the UK will get low back pain at some point in their life, and I think they sort of attributed a figure of 85% of low back pain is non-specific. I know identifiable pathology involved in that, and then 15% we can attribute to some sort of pathology. But yes.
Would you say that tissue damage is pathology?
To some degree, yes. Depends on the tissue.
Would you say a disc? Because I'm going to have a model just to explain, because it's good to understand that that in the annual. So we've got the disc, and we've got the vertebra. In the disc, in the outer 1/3 of the disc of the annulus, we've got nerve endings, right? So if there's damage in the disc, wouldn't we have pain?
Sure. Yeah, of course.
Well, not necessarily, because there's some very, very interesting research that shows that about 70% of all population actually do have some structural disc damage, but not all of them represent pain. And I think that's really interesting, because I would agree with you that there is always a biological component to the pain experience. And I'm very fond of the work that Dr. Mosley and Butler has done on the biopsychosocial model, and making it very applicable to kind of try to figure out what could be the different neurotags that actually turns like different patterns in the brain, which a biological reason, for example, can kickstart an emotion, can kickstart a belief, can kickstart a thought, or something like that. And I also think that it's, I mean, we can definitely go seeking for the cause and trying different causes, but I think we need to be aware that even though we might find a really good cause, it might not be the right cause. And if we do point out the cause for the patient or for the client, that can actually create some kind of a nocebo effect that can limit their beliefs on getting better, or ability to get better. Okay. So, I mean, sometimes I think that if we're not able to find a cause, instead of digging for the cause, I would rather go and see is there something that we can do to actually make you feel better? So there might be a cause and we might not know what it is, and we might think we know, and that might not be true. But let's look at your movement, let's look at your abilities and see how we can do something that you can do without pain so that you can get better.
Okay, brilliant, Anna, thank you. Yeah, let's look at this whole thing of finding a cause then, because this is really interesting. I take the point that you make as well, Anna, that although somebody might actually be shown on some sort of investigation to have issues in their lower back, they may have spondylosis, i.e., a general wear there. They may have some underlying pathology. There may be a disc issue. There may be some sort of slippage, a spondylolisthesis, something like that. These things don't necessarily relate to pain, right? And that has been shown.
It can be asymptomatic.
Yes. So that those individuals are non-symptomatic, even though they have some sort of identifiable physical issue. So I take that point, but what I want to pick up on, and I want to come to Joseph, is this whole thing of identifying a cause, because is this where we should be? Should the exercise professional, I'm thinking scope of practice here now, Rocco. You may want to talk first, and then maybe Joseph. But scope of practice here. Should the exercise professional, because there's a fine line between searching for that cause and diagnosis, and an exercise professional cannot be in the business of diagnosing a pathology in relation to low back pain.
So from my point of view, the aspect that I always say to, because I used to manage personal trainers, I always said, because I like creating fear to some people, especially because we deal with people. So sometimes when you're going to say, oh, you've got back pain, where do you hurt? Okay, let's do a bird dog, let's do a side plank, let's do a dead bug, whatever. And I always say, do you know if that person has cancer? Do you know if he has a coda equina? Do you know if there's any other radicular symptoms because of any form of diabetes that we don't know? And they're like, what? And I was like, yeah. What is your, like, who do you refer that person to?
Yeah.
Because I will never forget that. 4 years ago, when I used to work in Bournemouth in a big leisure center, a person came in and he was complaining with back pain, and from what he was saying, and because of my training, I thought there was something wrong with his lower part of his lumbars. And I just asked about, like, the first question you ask is, do you got any saddle anesthesia? Like when you go to the loo, do you feel, when you wipe your bottom? And he's like, oh, actually, I don't. And I was like, you need to just go. And he said, no, I went to my doctor and he said, I'm fine. So what I'm trying to say is, one thing that can sound as lower back pain, it can be numerous things. And what I would do is I would scope to this guy, because I'm not registered as a clinician, even though I've been doing my training, but because I want to keep the scope of practice, I would go to Joseph or you, and I would say, look, I think this is the case. And I'm not blaming the doctors. Yeah. We can all do mistakes. And I would say to Joseph, I think it's this. He complains with back pain. You see him, but then he needs to send him back in order for me to produce what Joseph wants me to do, plus your own experience.
Okay, brilliant.
And it's the same with what I would do as well. Like the patient would come to me, and I have a range of my own scope of practice of doing these tests, see if we can trigger the pain. If I can't trigger the pain, or I think something more serious is going on, they go into emergency room, GP, depends where. Like if I do suspect it's cancer or something, that's not in my range. So it's one of those things that if we can identify something and have a good view of our own scope, then we can quickly fast track this person to get the actual help they needed. And I think focusing on treatment, which from my experience is what I've seen a lot of trainers and chiropractors do, like rather than doing the actual testing, they'll just do treatment and say, well, we'll see if you respond for a few weeks and then send you. And we'll see if we can strengthen your core up, and then we'll send you when that doesn't work. And rather than that, it's send them away, and then when they're cleared, bring them back, work on some movement, send them, build that exercise program, make them resilient, keep them exercising and healthy. And in terms of the you know, unspecified back pain, I think a lot of the time we talk about that, you know, the classic MRI, you know, most people walk around with those, with disc bulges on MRI. These things can last for years, especially if we're recreating the problem constantly. So I think a lot of times when we have a problem, we go for the scan, we get an image of this problem, which doesn't help our, you know, fear avoidance and everything else. But the problem is people go, the disc bulge wasn't the problem. That was something in the background that was there, pre-existing to the pain that they're in now, if that makes sense.
Mm-hmm.
Yeah.
So sometimes people go, well, the disc wasn't causing the pain, but the disc might not be the thing that was causing the pain this time, but it might have done in the past, if that makes sense.
Yeah.
And that goes wonderfully with what Anna said before, the fear of avoidance of movement. I'm not a fan. I'm not going to say I'm not going to be disrespectful, because Mosley and Burke did an amazing job with the protectometer and with all the biopsychosocial. I just think that they're waving the flag too high, because there are 100 models and we need to understand the limitations of every model that comes out. But exactly Anna was saying before, that interlinks so wonderfully with what exactly you're saying, because of that person, if he had pain because of the disc or because of any tissue, ALA, PLA, ligamentum flavum, disc, whatever, he created an inhibition in his movement because of his past experience that will lead to more problems.
Mm-hmm.
Yeah, that's very interesting, actually, because the protectometer, which is actually basically the model of trying to figure out which signals are danger signals and which are the safety signals. It can also be looked through the allostatic load lens or something like that. So it might not be the reason, but it might add to the actual problem, which is multifactorial. And I think you have a really nice point, a really relevant point, Rocco, because there is actually need for a multidisciplinary approach on actually working together, because of the complexity of the situation of any pain experience. Actually, on my team we have physiotherapists and different medical professionals, so we are constantly kind of in a dialogue. Okay, I'm not really sure that that is the way that the person should be responding, can you look at that? And so there's always something that is being monitored without necessarily actually frightening the client as the first thing, but we can just talk together about, okay, what do we do, and which tests do we want to do on the client.
I get that. Multidisciplinary approach would seem to, that speaks a lot of sense to us all, I'm sure.
Yeah.
And that's the most important part, Anna, and what Joseph said, that as you can see, Joseph stays in his range as a chiropractor. He says, if I see something, I'm going to pass it on. But one, I need to just say, I've been as a personal trainer for 20 years now. And one thing that I'm blaming myself for that too, in the beginning, I was a Swiss knife. What do you want? I'll do it. I'm your man. Pain, birth, bakery, make your coffee. We need to respect our profession, because we actually prescribe exercise for health, for fitness, for performance. Like personal trainers should not take themselves lightly, and they should put all their effort in providing the best quality of training by getting well educated and not forgetting the fundamentals, the basics. Like, learn your anatomy, your biology, your physiology, 101. Don't go crazy, just the basics.
Okay.
That's just irrelevant. Yeah, sorry.
No, go on, Anna, you go.
That was just a great point, because I think that we definitely need to talk scope of the exercise professional, but also are there any angles where they actually lack understanding of, for example, the complexity of pain and how it actually, the red flags, what are the red flags you need to be aware, and what actually can be the yellow flags that you can self-contribute to actually the complex picture of pain.
Excellent point. Excellent point.
Yeah, especially wording as well. You know, you have some people who say this was, I had a person come see me who said their surgeon had told them their back is made out of glass. Now, why would you say that to someone? Like, that's going to have a massive psychological impact. So sometimes just the wording, and I wasn't there that day, it might have been used out of context or whatever, but wording has a massive place in pain and, you know, the road to recovery.
No, that's really interesting. We're sort of building a picture here. I mean, I think what Anna has referred to, and what you're referring to there a little bit, Joseph, as well, is that medicalisation of back pain, and then, you know, so it always searching out that cause, and then I've got an issue with my back, I've got a disc problem, so this is going to stay with me. That might then result in fear avoidant behavior, etc., and these are issues, and guarding type behaviors where we change movement patterns because that individual is protecting that back that's made of glass, Joseph. So as you say, the words we use are very important. So I just to say, I guess one of the things I'm trying to do with this call is I'm introducing this subject because currently EuropeActive don't have actual educational standards in the area of low back pain management. So I guess this is maybe giving us some clues, because I'd like to develop that, but this is giving us some clues as to where we could go with that. So there's got to be an understanding of the importance of the words we use, and that relates a lot to that biopsychosocial model approach. There's got to be an understanding of the anatomy going on here and the physiology around low back pain, because you know, if you're going to understand, you're going to refer, etc., then you need that understanding, and you need some understanding of pathologies as well, in order that you might then know what those warning signs are, what those contraindications are, in order to refer to other people. The other side of it, as Anna is referring to, is an understanding of pain and pain mechanisms and how people respond to pain. So I'm starting to build that picture of what those standards start to look like. But Rocco, to come to you and to come to that point, then, that people need an understanding of anatomy, they need an understanding of pathology. You clearly believe that.
It's a really important aspect, because it's if you're like, I don't want to say mechanic in the most structural way, because people like I've been blamed, because sometimes I might post something and say, you know what, like when we've got flexion and we like add load, we can see what happens, and sometimes, you know, we can create a fissure, which a fissure is like a radial, let's say, line that goes straight through the annulus, and if we add too much load, the nucleus will come out and create that funny bulge in the back that you can see there, that can irritate the nerve. And people say, oh, you're such a biomechanist, where's the biopsychosocial model? And I was like, have you seen me with a patient? People like putting flags in, you're this, you're that. We should drop that. We should be better people. And what I always say, be a good person. Don't be I cannot use the word. So be a good person. I love you guys, and I love whoever is listening, and that's what I want to do. Our purpose is to take people away from pain and give them something better back. That's what we do. That's what I do. Human optimization. That's what we want to do. We want to make people be in charge of their lives, picking up their baby. And if I'm going to say, don't flex, it's not a bad word, because I'm going to explain what I mean. And that's why, like, I'm using Jerome Friars from Dynamics Spine Models, because I want to teach them. That doesn't mean that I'm a biomechanist and all the thing is about kinesiology.
Sure.
But in order to understand the basic fundamentals, how are you going to split something apart when you cannot put it together?
But the interesting thing about the biopsychosocial model is also that the biological part does matter. So you cannot actually just take it out and then take the psycho and the social things and give them more effect on some kind of pace. So because the biologics do matter. And I think that sometimes I can see the biopsychosocial model gets kind of misinterpreted, because then I see clients getting referred to a physiotherapist for their elbow and to their psychologist for some stress. They might be under a lot of stress. And the stress does matter and all this, but the psychological thing in this model is very exciting in this way. Like, if the patient or the client does have something with their back or their elbow or their knee or whatever, what are the thoughts that makes them think, and what are the feelings, what beliefs that triggers? So that kind of the psychological thing, which actually is related the emotional load related to the pain they're experiencing is very, very interesting. So when I see clients getting referred to the psychologist and say, that's because we are use the biopsychosocial model, so you need to see the psychologist because there's so much stress in your life, then I can also get kind of like, well, let's just not put all in the stress bucket.
Yeah, but we also need to be extra careful when we use the word stress, because stress, it has one of the fathers of using, like, created the word stress, and he created the gas syndrome, Hans Selye, back in the early 30s, and he has an amazing book, The Stress of Life. He just explained that without stress you would be dead, because what we're actually doing with training, we create stress. Now it's our ability, our experience to know exactly where that stress threshold is in order to build, for example, more bone, in order to get more callus, in order to get more load. So that's when doctors are going to say, when they see an x-ray, oh, you've got a degenerated back. No, I'm not. I'm a power lifter. I put 200 kilos in my back. That's what my bones are going to do. Form follows function. Dr. Wolf said that years and years ago. But again, and I completely agree with you, because everything is blown out of proportion. And when you see the biopsychosocial model with the nice 3 circles, bio, psycho, social, if you have a patient coming in with 8 pain, try to talk to him about the stress of his kids or the stress of his life. The only thing he's stressed about is like, take the goddamn pain away.
Mm-hmm.
And then we can say with psychosocially, which I'm 100%, because I do that with especially kids when I've got athletes. Have you seen a kid when he's stressed, or whoever is a parent, when you tell them off, they're like this and they put their head down? Don't you think that has an effect in their pain when you put all that tension in your body? Like, it's so interesting that we need to be able, nothing is perfect in life, and all these circles of the bio, sometimes we need to enlarge the bio, or we need to thin it. We need to enlarge the social, we need to thin it, or we need to enlarge the psychological or thin it. Always in a really good context regarding what, and it depends who we have. It's individualized.
Joseph, any thoughts there?
Yeah, definitely. Like, you see people who, they've slipped and they've fallen. Sometimes, that is just purely a biological thing, that you just, the tissues are damaged, or you're just trying to, deplete those sensors as much as you can to just keep them going and moving. And then on the other hand, you've had someone who's heard something. I said the backward glass before, but you hear from, in my profession, they've gone to see another professional. Oh, my spine's out of alignment. And if they truly believe it needs to be clicked back into place every so months, a few months, which has its own psychological component, which we work with to try and get them out of that way of thinking as well. So I think definitely what Rocco was saying, trying to change those areas and see this patient you can't put him into a box. He's got his own way of dealing with things, and trying to focus on what he has most, prioritizing basically what he needs to see first, because we'd all love to have a chiropractor, personal trainer, a nutritionist, everything, but for a lot of these people, they can only go to one place, and you need to decide, am I the best person for them, or can they go somewhere else? I have people who come to me and say, oh, my back gets tight, I just need maintenance adjustments every month. I think that they would be better going to an exercise professional now and actually making themselves more robust. I know people won't necessarily agree with that all the time, but if people can only afford one thing, pushing them into what they will benefit most, and human optimization, like we were talking before.
Yes, absolutely. I couldn't agree more there. Really, it's just in that situation that Rocco mentioned. If you had an 8 out of 10 pain scale that people just want relief from that, well, that might be a situation where the exercise professional is out of their depth, and they want to refer on in that situation. Whereas, as you and I both know, Joseph, we do get people that keep coming back, and we hear that mentality of a quick click and I'll be right again, and all of that stuff. But those individuals, that chiropractor, that osteopath, should be working with an exercise professional who at that point they should be referring on, so we actually get some long-term solution to this problem. So again, returns to our point about working within that multidisciplinary situation, and we all have a part to play in that. I would also pick up on the point of the biopsychosocial model, exactly as you've all said, really, that Rocco was complaining there of being labeled as a structural guy, but he's not ignoring the psychosocial stuff. It's all part of the picture, just as Anna made the point that the biopsychosocial approach recognizes the importance of those structural aspects as well, but within that overall framework. So all that sits together really quite nicely. So, okay,
one thing
good. Go on,
social as well, the social part of it, we probably both see elderly patients who come to us who we're the only people that they see all week. So we are doing that social part of the health for them, because that's the only time someone actually sits down and listens to the problems, unfortunately. But that's what business we're in as well.
And that's the important part of, like Anna said, you said, Julian said, about regarding the words. Words matter.
Yeah. Yes.
As you said, they're coming to you, or and they need that, feel that comfort and that understanding. And fear, that's Anna, if I remember correctly, on the book, it says about fear that actually all the stress, all those, like, it's different if you're going to the garden and cut yourself because you're expecting it, and it's different if you fall. That will amplify your pain because it's stress. It's, oh my God, what just happened? So I always give that example that if I'm listening the radio and the presenter is speaking, if all the stresses are amplifying the pain, that doesn't mean that the pain is that the presenter is speaking, screaming on my radio. I'm just amplifying the sound. Mm-hmm. So all these things can play a huge role of amplifying the volume of the pain, and can create a worse environment. And that doesn't mean that the pain is extreme.
And I think that's actually a very crucial point of the part where you educate your client. Them understanding that the circumstances that they're in actually can amplify their pain, and they are actually able to do something about it themselves. Because when patients come or clients come and they are like, fix me, you should click my back, or you should massage me, you should do something like that, and that's where they're coming from, then it's a very exciting road actually to kind of get them to acknowledge that they can do something themselves. And they might not be ready to hear that. So I actually really like the thing you said, Rocco, about amplifying the circles and going with the least resistance. Actually, we always ask our clients, what is the thing that you have the least possible resistance towards? And they choose, okay, I have a resistance towards working with this, so I won't do that right now. Okay, let's work with something else. So they actually get to pick their circle to start to work with, which correlates with their understanding of their pain picture. And slowly we can start to move them and create some positive experiences that they can actually also turn down their own pain.
I think yeah, that's something I worked really hard with, Joseph. I was just going to ask you actually. But in a clinical situation, that trying to move that person, and this relates clearly to the exercise situation as well, trying to move that person from a more passive approach to their pain to a more active approach, from an external locus of control, relying on the medical profession, chiropractors, osteopaths, whoever, to a more internalized locus of control where they're taking responsibility. And obviously the main example of that is encouraging them to continue to be physically active, and not to say, look, hey, you're in pain here, you've got to reduce what you do. We have to manage that activity, but we need to encourage a positive response. Joseph?
I always try and take into account like what kind of motivations that person has. You have certain patients who come in and they go, right, I feel great, what can I do in the meantime? And that's when people can set exercises and things like that. You can go and see this trainer, this is where we'll push you back into being self-reliant. But some people come in and it's like, it took all the motivation to get out of bed, get dressed that day and come and see me. So you have to sort of start sometime with passive treatment. Like I see a lot of posts where people are putting themselves into boxes these days, sports physios, kettlebell physios and all sorts of things where it's like exercise is the best medicine, this is all we should be doing. There's a place for passive treatment, but I do think, I obviously agree that exercise is the best medicine and everyone should be doing that. But that's up here. Some people, they're not ready to go and do a couch to 5K. You need to get them even just start planting the seed to think about that, if that makes sense.
That makes absolute sense. Yeah.
I was at a very interesting seminar one day last year with Sandy Hilton. She's a very, I think she's a well-known pelvic pain professional. And she told about helping clients to actually, when she started with doing the manual treatment, so she tried to find, okay, if I pull here or if I do this, do you then feel more or less pain? And found something that actually was less painful or made the pain turn down for their pain. And actually then taught them to put their own hands there and kind of try to replicate the thing that she had found has worked best for them. So they could feel, okay, my own hands are actually able to reduce my own pain. That was a really interesting approach. So we can actually move away from thinking, okay, you should be doing exercise, but sometimes the exercise is actually the client replicating what the manual therapist just taught them to do in terms of a touch or a sensory experience or something like that.
Like foam rolling your thoracics, or trying to get that thoracic extension before doing overhead presses. And that's going to keep you out of shoulder pain that you usually get because you can load the appropriate tissues. Exactly, yeah.
Yes, no, it's all about levels, isn't it, really, guys? When these guys come to see you, what is appropriate. I wasn't. I was suggesting that they shouldn't take a passive approach to their back pain. I wasn't suggesting, Joseph, that passive treatment isn't of value. Of course, in some situations that's very much of value. Okay, guys, no, brilliant. Let's just maybe move it on a little bit. So I'm thinking that we've got to be very much, we're all accepting awareness of scope of practice. We're not in the business of diagnosing, but we need an awareness of conditions and pathologies, etc., etc. So, we can refer where appropriate. We want to work within a multidisciplinary team, all of these great points. But I'm thinking, so somebody comes to you, Rocco, and they've got back pain, and you want to assess where they are and what's going on here. So any assessment protocols you would particularly use? How would you approach that situation?
Well, everything begins when the person comes to you, because he walked to you, you give you a handshake, you see how he stands. So if we can say the assessment starts when you first lay your eyes on him or her. So that's the first part. Then I think building a rapport would be it's one of the critical aspects of having really good questions so you can find out what exactly is happening. And there are many variables like age, kind of profession they do, is it the first time they have back pain? What's the pain during the day, during the morning? There's so many different questions you can make, and there are brilliant books out there and brilliant courses. I know you're creating something, Julian, in the future, so that would be really interesting. And then there's specific tests, like if you want to do, like to check if it's like anything that could be with their disc, and any trainer can do that, like from a chems test to check if there are any facets. You can do just a compression test to see if, and it could be nothing. But I would always start with, how do they stand? How do they walk? How do they squat? How do they sit? How do they stand up? Basic things, because if every time they move badly, they're going to be creating a small micro injury. Different people have different thresholds, and if you keep doing the same thing over and over again, it's not going to get better. It's like rubbing, your coat on your desk all the time is going to create a hole at some point, if I can use that term. So if we can actually start creating some good ways of moving, if we can learn and understand how we can stiffen up the core and why, and what that creates, because we can explain it anatomically if you want, but why is that? Why do I need to stiffen up when I'm going to pick up my baby, when I'm going to lift something up from the ground, if I'm going to be squatting, deadlifting, whatever that is? Why do I need to create that fine dimmer on my core in order to lift better? And then everything's fine until you put load. as Coach Dan John says, everybody's singing and dancing till you put load, and then you see everything goes bad. So I check everything with, as I said before, with no weight, no load, nothing, basic movements. If we're good, then we're going to start applying a bit of load and seeing how things are changing.
Excellent. That really interesting. Yeah, that was an interesting analogy, Rocco, of the rubbing on something and eventually you get a hole there, and it sort of puts me in mind of that what is that phrase? Pattern overload. So it's like in the gym, we get people doing the same things all the time, isolated movements in a single plane of motion. And then we're surprised where eventually their shoulders start hurting,
Yeah.
or their back starts hurting a bit. Well, we keep doing the same thing and keep stressing the same tissues in the same way.
That goes back to anatomy. Sorry for interrupting, but that's why I always say go back to your anatomy, see what the joint can do, and use that range of motion that the joint has, and not correct, because if I'm going to say correct, I'm going to be a correction specialist or whatever. But just find that good movement, because I'm a big I like good posture, because I'm digging into a rabbit hole with meningeal releases and how it affects with the meningeal pressure in the brain, which is, I'm not going to go into that, and you can see in functional MRIs how it affects your whole system. So the thing I want to say, if I have it here, with the brace, for example, we know that the muscles attached on the TVPs, right, in this angle. Yeah. A lot of people, because of their, I don't know, as you said, putting bad patterns all the time, they might be pushing when they're going to lift something on this position. Yeah. If you don't brace and you move something with this way, you're going to have problems either in the facets or in the disc, and you can start creating fissures. But if you create that brace that we say using the core, this in an angular position is going to pushing it down with a good balance, and then you're fine, you're good to go to put load. So it's a prep stage of actually putting load in any part.
Okay, fantastic. I mean, you're opening up a whole can of worms there, because we could start to talk about, obviously, just for the audience there, Rocco was talking about transverse processes, TVPs, part of the spine, but also he made mention of bracing. Abdominal bracing, and there was a whole debate, and I don't know if that debate is still raging. I think it's probably over, but
what with the transverse abdominis?
Hollowing and bracing and TVA activation. But hey, whoa, steady.
Every time, try to suck in and push someone, and if you can stay stable, I'll change careers. Yeah.
Right. Anyway, yes, right. No, yes, good.
Just suck in and push someone, and then take someone to brace. Like, keep that thing. Like, can I tell you? And I always say that if I'm going to punch you in the gut, would you suck in or would you push out?
Fair point, Robert. And I'm very aware.
I'm not going to do it. Don't assume me.
Yeah. Hey, I actually, this was my thesis coming out of osteopathy was all about hollowing and bracing. And
there's one paper that says that, and I think it was is it New Zealand, or I think it was New Zealand. One paper,
I think it was. Yeah.
And everybody's starting to
Hodges and I we won't go there too much. All right, but what I see there is or what I picked up on was, that really a lot of what you were talking about was postural, static postural assessment, looking at the way they are, but also functional assessments. And really interesting to hear that point on it all changes when you apply load. And I think that's an extremely good point. I wanted to talk to Joseph a little bit about that as well, because in terms of your assessment, Joseph, obviously some of your assessments from a chiropractic point of view are going to be very different from those assessments from an exercise point of view.
Yeah, I think in terms of what we have in time, I'm quite lucky, because when I'm working for myself, I spend a lot of time with patients to try and work on movement. When I've worked in other clinics, and you usually, as an exercise professional, remember this as well, this might be seeing 20 different people that day, and their time constraints might be 40 to, sometimes I've seen 20, 15-minute slots. they're not going to go through all those movement patterns. What they're going to do is have a feel through the back, see what's stiff, have a feel through the nerves, just checking tension basically everywhere, and then just working with that. So not looking at quality of movement in some cases, and not looking at how often people are moving, and sometimes not getting the background of, you know, what their day looks like. So it's just what you see in front of you then and there, which is very different from you guys who can go, right, well, I noticed that when you did the deadlift, you braced properly, you did everything right, but then when you took the weight off the side, you went all floppy and pulled the weight off. That can give you an insight to, well, maybe the pain's coming from the rest of the stuff that you're doing each day. That makes sense.
Yes. No, absolutely. I mean, yeah, I guess I'm thinking in my head, you know, where does the line stop here? And it's something I've battled with a lot over the years. Is yeah, I'm all for the, you know, postural functional assessment with load, etc., getting them to lift, you know, do the right things in the gym. That's all part of our function here. But it's an interesting one, isn't it? Because if we go back to the screening point, you know, if we're going to refer on, how do we identify? I think we can only identify as exercise professionals on the basis of the things that are reported by the individual that might raise some concerns and red flags in our minds. Rather than, you know, it isn't really the place of the exercise professional to be doing tests like straight leg raises, etc., etc. So we have to be very clear on that scope of practice. And I mean, from an assessment point of view, I'm thinking you can by all means talk about the physical assessment side of things, but you might want to talk more to the psychosocial side. I don't know, but I'll leave that to you.
Yeah, well, I have actually two kinds of things I look after, and one of them is when I look at people move, I try to actually I really like the metaphor that Dr. Eric Kopp, who founded C Health or Set Health Performance, he talks about body mapping. And I try to see, okay, if there's anywhere when the client moves, there are kind of areas that are not well mapped. Do they lack control? Do they lack sensory input? Do they lack fine coordination? And from that point, I try to kind of add something to make the map more clear. So from the neurocentric perspective, it's just thinking, I really try to be aware of not telling the client what about something that they're doing might actually hurt them or harm them, because they're so afraid to move anyway. I mean, over 60% of my clients do not have a regular training routine. So because they're afraid to do something wrong, and they're afraid to do something that will hurt them more. So I try to say, okay, I think that for your brain to actually have more predictability about your movement so that you are more safe to move, then we need to kind of give you some more input. And then we work from that. Do they need to actually, I look at where do they look? Do they look down on the floor where I try to squat all the time? Should we try to actually do something else to give them another point of focus? Does the head bobbles or something like that might actually show a vestibular issue, and give them some drills to actually stimulate some of the senses that might not be well stimulated. That's one part of that. And the other part that when I wrote the book Painless, I used enormous amount of time to actually do a test from the like with the inspiration from the protectometer model, but also from the endocrinology perspective. So I one part of the test asks the client how they're doing, how they're feeling, and they kind of rate on the severity of the symptoms. They can be their appetite regulation, there can be their digestion, there can be their mental conditions, or how they're feeling, inspired by the POMS model, for example, profile of mood states. So a whole lot of these, I try to map all these biopsychosocial factors to kind of see, okay, does that tell us of something about the load in their life? And the other part of the test is actually things they do. So the lifestyle and habits or something like that. Totally unsexy subject. And very, very hard to sell the clients on actually that kind of matters. But we do know that lifestyle matters a lot. For example, the quality of sleep can actually make your pain amplify or turn down for the pain levels, amount of, well, the regularity of the meals. Do they get enough calories? Do they have too high blood sugar because they actually do not get well consistent meals, stuff like that. So I do assess also their lifestyle habits to try to kind of help them understand that the lifestyle changes can help them recover better and feel more pain-free, so that we can get them to move more, which will actually do the positive circle of movement.
Great. Okay. No, absolutely, and I totally on board with all of that, and a very holistic approach, and the right approach. Yeah. Okay. I'm aware that we're sort of. I think this conversation could go on for quite a while, guys. Actually, but I'm aware we've got about 10 minutes left, and I wanted to talk about sort of exercise. The exercise side of things, the exercise prescription more specifically, I guess. But we've got a couple of questions in from the audience,
cool.
and this is quite a good one. So, can core training damage the lower back? So, anybody want to speak to that?
Yeah,
Absolutely.
Okay.
Depends what kind of core training.
Joseph, you go first this time, because I know Rocco's going to have a lot to say. I'm sure.
Well, I'll just start off nice and easy with the one that everyone picks on, which is the sit-ups. If you're doing core training thinking you're going to protect your back by building a bigger core from sit-ups, that repeated flexion is going to damage, your ligaments, discs, all sorts in there. So it's obviously how you do it. It's a very generalized view of core training, but the right core training is fantastic, but it has to be appropriate to what your goals are. And I think when people do core training, a lot of the time it's just the general program of sit-ups, leg raises, side plank, all these exercises. Appropriate core training looks more like the Meningeal's Big Three, and then also loading the patterns, loaded walking, things like that, that will keep core tension all around the core rather than just focusing on isolated movements.
Oh, very interesting. So Meningeal's Big Three, bird dog, modified curl up, is it something?
Yep.
Yes,
Yep.
And there's one more as well.
Side plank as well. Yeah.
Side plank. Oh, okay, fine. So, but the point you're making there is that okay, we can say core training, but what is core training? And if people are including sit-ups in that, or the traditional sit-up, then that ain't great. I mean, I was reading something earlier, 3,300 newtons of compression forces exerted on the spine in a traditional sit-up.
Yeah,
so, here we go. Rocco, go for it.
I'm not going to get into debate. I'm just going to say what's proven. And what is proven can not be, because we misinterpreted science. A lot of people say your spine can take about 18,000 newtons. Okay, can you show that to me? Bring me a person and do that. If his back gets injured or breaks, it's on you. So when we need RCTs to prove our point, even though we have seen lots and lots of athletes, professional players, general population, elderly, young people, and we're waiting for a paper to say how much we can put, that makes me a bit like we're so blindfolded of like that RCT kind of, because I'm not blaming RCTs. I'm just saying clinical trials. I'm just saying that we cannot kill someone. It's not ethical to prove a point. Now, if you take Eddie Hall and trying to see how much back extension he can do, which he had back pain as well, but trust me and him, we don't have the same newtons that we can put. So
yes.
what we're trying to say is, what we need to do to be more efficient, because some people, like you take a coat hanger and you can go like this and you can break on one snap. That's one person. With other ones, or with paper clips, I used to do that when I was a kid.
Yeah.
You can go 100 times and nothing snaps. Yeah. So why would I go on a sit up and not try to find something that's more efficient, spare my spine, because I'm a gardener. I'm a construction worker. I sit too much. So I'm like a T-Rex all day. Why would I stay in that position and not train the muscles for sparing my back? Because core training would be different with someone with flexion intolerance. Someone core training would be different with someone with extension intolerance. Some would be different with different irritation of the facets. Some would be different if he has problems with facets or anything. And someone we need to do any like farmer walks with just 5 kilos.
Yeah.
That was a really interesting one, Joseph. Do you want to the farmer walk thing? Because you brought that
or
up.
Suitcase carry.
Suitcase carry. Yeah.
I think that's one of the easiest exercises you can do to increase core strength and increase full body strength. I would say picking something up and you can always add more weight. I used to use the trap bar, which you can go from 20 kilos up to bonkers weights. I think it's one of those ones that it teaches you to brace correctly, and it teaches you to keep a straight spine whilst you move in your other limbs as well. A lot of these movements that are not bad, but sort of more risk to reward ratio than other exercises are the ones that teach you to move your spine rather than your limbs around your spine, if that makes sense.
Yes. No, I totally get that. Sorry, I was slightly distracted there because I was just reading a question.
Anna now. Anna?
I have just a little addiction because my rabbit hole this time is actually how the vision and the vestibular system work on posture and on actually core activation. So in my experience, I have been very fond of using rolling and rocking and some of the exercises that Gray Cook he has in his book Movement. And he has kind of a lot of flow charts on when to prescribe which kind of rolling with the upper body or with the lower body, or what kind of rocking movements. But with my clients, I've seen very great results actually incorporating both the visual drill and the vestibular drill and some kind of rolling or rocking to actually get them to be able to tolerate more load. And then afterwards, the carries are just great, or loaded carries or something like that, because then it's kind of, there's connection that gets turned on. So there would be actually a suggestion for many exercise professionals to try to chunk some kind of sensory input with some of the exercise that you're doing, because that might actually give faster results.
You just use the word chunk.
Yeah, should I explain?
No, it's a really good word. I wrote, of course, I wrote many years ago in this area, chunking. I think it was Paul Chet who used to talk about chunking.
That might be that, yeah. Well, I like chunking from the learning perspective, actually. How can we increase the load while actually not increasing the mechanical load? Can we actually increase the neural load so that the client learns faster? Because when you increase the load, you learn faster. Whether it's good learning or bad learning, it doesn't really matter. You just get better at whatever you're doing, amplified. But I really like to increase some of the neural load and a bit more complexity and finer motor skills to actually kind of get the client to be better at moving faster.
Yes, I guess that speaks to the need for progression, and I mean there's a question here which says, well, how do you feel about training strength in so-called bad postures? So we could be reinforcing faulty movement patterns, faulty positions, etc., and we can see that going on all around us in gyms, I guess, all the time. Did you describe it, Rocco, as a Tyrannosaurus kind of posture?
Yeah.
And then we go in the gym and curl up in a ball on the floor. I mean, it doesn't make.
I'm not like sense. A lot of people think that first of all, we cannot cheat biology. Whatever we say, we cannot cheat biology. We cannot cheat anatomy. That's how we are. That's how we're based. Everybody's different. Some might have different curves. Some might can take more load. Some not prepared to get any load. So to the question, how do you feel about training strength in so-called bad postures? It's out of context. If you give me a context of what do you mean bad posture, I can literally say, because we've seen, you know what? A lot of people take pictures of powerlifter or strongman wrapped around a big bull atlas stone to bring it up. And they see, oh, he did the lift. I was like, yeah, have you checked how long he spent in rehab or what's going on? And you cannot take a strong man or a strong athlete as an example of how you want to go, because this guy is trained 8 to 10 hours a day with heavy loads. Now, if bad posture or bad position is not good, try to be a T-Rex and try to breathe in, relax, stand up neutral. It's a zone. It's not a posture. Don't start blaming me. Neutral we can use, and breathe. You can have more capacity to breathe. So posture plays a huge role, and we've seen that with people with depressive kind of behaviors, that because they spend so much time in a hunched position, because they couldn't breathe, their heart start palpitating in order to get more oxygen in, and that's why they had all this. So a mom that needs to pick up a baby or just thinks about the baby and not the posture, at some point you might experience pain. Is it 100%? I don't know, because we're all different. But from my experience of what I've seen, all new moms, bless their kids, they'll have either, I don't know, Joseph, in your clinic, unilateral pain and contralateral lower back pain, like 99% of the time.
Yeah. I think the focus on posture as well. When I went over to see you in Greece, Rocco, Tony and Dean had really good points about how, you know, we could be so focused on, you know, trying to get people's feet parallel on the squat. And what he was talking about was you can't see their anatomy. They may have different shaped hips. One of them might have that equal, you know, it might be easier this way, 1 foot out because of the shape of the hip. Forcing perfect form is actually going to create more wear and tear in the hip and then get them into pain. So I like their drill where they talked about it could be a sort of bad posture, but they said, how does that feel for you? Change this. How does that feel for you? Better, worse? If it's not a complete, yes, that's better, then they go back to how it was.
Exactly.
If that makes sense.
There's no textbook.
No. That's a very interesting point, actually, because when I was in powerlifting, then my coach, he really was very, very focused on putting my feet like this special way. And now I know that posture is kind of as a result of very, very many different input. So when you fix that, then the posture actually gets better. In my case, there was a lot of vestibular work that needed to be done actually to get my posture to be automatically better. And I also did the T-Rex thing with the very heavy load. So I can talk all about the issue of tissue tolerance. I actually just went into powerlifting without any prep whatsoever because it was just really, really cool to lift table weights. But it took me, I don't know, maybe 8 years to recover actually and do all the prehab or rehab work that I hadn't been doing before that.
Thank you so much, Anna, for that comment, because a lot of people are not, because I'm also coming from strength, and no one says the side effects, because it's a trade-off. Like, you want to deadlift 300 kilos, there's going to be a trade-off, buddy. You want to put 250 kilos in your back, there's going to be a trade-off. Like, and as you said, and it's a really excellent point, and thank you for saying that yes, it took me 8 years to recover.
It's could I just say that, I mean, yeah, some really good points there. I mean, Joseph's original point there about talking about the squat and foot position, and you know, there's no one solution here. No. You have to work with the person. I guess it's a central principle, interestingly, of osteopathy, that the body is a self-healing mechanism. So you know, we work with that body. We don't impose ourselves on that body, and we try and try and create the environment where it can function better. So that sort of speaks to that to that point. That you know, there isn't one fixed solution because everybody is very different, and we have to work with that on a very sort of functional level, a very holistic level. So yeah, I think that's a really good point. Okay, yes. So I see that we're just doing a poll of the session, which tells me that we're over time here, guys. I could basically continue this conversation for some time. Really interesting, and maybe we will do another one, and we'll pick out a specific aspect of this. Maybe we'll talk a little bit more to the exercise side of things. Actually, that's what's just occurred to me. That's what I was thinking. I was thinking of that approach of, you know, that progressive approach, and I know back in the day there was a lot of talk around, you know, isolation to integration. So you start with those exercises which are more maybe about muscle imbalance, maybe more about mobility, general mobility, but then you progressively move to those more compound exercises, and you might work with various movement patterns in order to achieve that. That's very checked, actually. You know, push, pull, rotate, etc. All of that stuff. So, but that speaks to that progressive approach. I can't resist it. Anybody want to pick up on anything there? And in terms of that, in terms of that approach.
Well, that's definitely how I train. You know, just picking one or two basic exercises that cover the whole body in a training session, then focus on recovery, and then adding load over time. I think we can focus on a lot of corrective stuff. And again, what Tony and Dean were talking about was sometimes we're not hitting that threshold to ever improve if we're constantly just doing, you know, all these little curls and things like that won't make a difference to us. Does that make sense?
No, that's exactly that's really interesting, that, isn't it? That, you know, we can, you know, we need to move on. Yes, we need to address situations that might exist, and there may be some corrective exercise within that. But you know, ultimately, we need to move on. And I have seen, yes, Rocco.
No. Just strength and endurance are two different things in core. A lot of people think they have to create a really strong core and they forget endurance. That's a really important part, like from my point of view, because it's before we're talking, remember, Julian, we're talking about a Mini Cooper. If you try to put 500 horsepower in a Mini Cooper, things are going to go really bad. But if you create a chassis that you can actually do that, like create endurance in your day, that you can, as Anna said before, I wasn't ready and my tissues weren't ready. So if you create a pattern and a protocol that can tissues your anterior longitudinal ligaments,
he disappeared, right?
I think we just lost Rocco. Oh, that's a shame. He was in full flow as well. Okay, look, guys, I think maybe he'll suddenly reappear, but maybe not. So look, I think we've gone over our time.
Okay.
Oh no, he's back. He's back.
I'm back.
No, do you want to finish that point, Rocco? I think.
Yeah, I was just saying that how important it is that endurance and strength. Like first of all, you need to be able to endure in order to bring that strength. Because if you're focusing on strength, things are going to go really bad. Trust me.
Yeah. Okay. No. Good point to end on. So I think, yes, we have to finish it there, guys. Your contributions have been excellent. We've sort of run it slightly different this time in that we free-willed it a bit. You know, but I hope that our audience can maybe take some aspects of that and it will spark some thoughts and maybe it will spark some further reading, etc. And hopefully our audience will rejoin us at some point in the future, and we'll do something else. As I say, you know, we don't currently at EuropeActive have educational standards in this specific area, and I would like to work to produce something there that would create some sort of standardization. There are a lot of issues around scope of practice, etc., that we have to be very clear on. How do we work in those teams? How do, you know, what shouldn't we do, etc., and we need to get that level of professionalism in all of this. But it's a fantastic area to work in. It opens up so many different discussions as we've seen today. There was a question, my apologies to I think it's John Sharkey, actually, who I know is a clinical anatomist and exercise physiologist. Hi, John, who asked about fascia, and we didn't even talk about fascia. But maybe next time we'll get
so
there.
Important. So important. Thomas Meyer's book and fascia is getting more. So it's a whole new chapter. So
so we'll do a session specifically on that, anatomy trains and all of that stuff. Fantastic. But yeah, so thank you for today, guys. Great stuff. Nobody fell out, which was good. We all got on pretty well.
Thank you.
Nice. So thanks.
It's also really exciting to kind of crawl into your heads as well, and like, how are you doing things? It's just really, really giving. So thank you for today.
Brilliant.
Thank you, everyone.
Thanks, guys. Thanks, everybody. Thanks for watching. Cheers. Bye-bye.